So greetings, everyone. We're so glad to have you join us for this month's PCRC webinar. We will be talking today about concurrent hospice dialysis care, and we're so delighted to have with us today Dr. Jane Schell and Dr. Natalie Ernecoff. Dr. Natalie Ernecoff is an associate policy researcher at the RAND Corporation. Her research focuses on the developing, implementing, and evaluating of systems-level palliative care, hospice, and home care interventions. And her work focuses on healthcare system informatics, electronic health record-based interventions, systematic identification of serious illness populations, and collaborative models of palliative care delivery. So all things implementation science and palliative care. She's worked across kidney disease, dementia, cancer, and critical illness populations, and she's experienced in qualitative and mixed methods research, implementation science, and clinical research. Dr. Ernecoff holds a PhD in health policy and management from the University of North Carolina and an MPH in behavioral and community health sciences from the University of Pittsburgh. Accompanying her is Dr. Jane Schell, who's an associate professor of medicine at the University of Pittsburgh within the section of palliative care in the division of nephrology. And she serves as the palliative care advisor as well for Dialysis Clinic Incorporated. She received her master's in health sciences evaluating communication challenges between nephrologists and older patients with kidney disease. And her academic passion is improving palliative care within nephrology through education and innovative practice models. She developed a nationally recognized communication training, NephroTalk, designed to teach nephrology fellows and nephrologists palliative care communication skills for treatment, decision-making, and end-of-life care in patients with kidney disease. And her current research interests are focused on innovative programs like the one you're going to hear about today to improve palliative care and hospice services in patients with end-stage kidney disease on dialysis. As you can see here, in the webinar format, we have our attendees automatically muted. So please send your questions via the Q&A feature, which if you just sort of hover your mouse over the bottom of your screen, you should be able to see there. And we're very much looking forward to an interactive conversation today. And I'll turn it over to you, Dr. Ernecoff.
Thank you so much. It's so good to be here with all of you today. So today, Jane and I will be talking about concurrent hospice dialysis care. This is an evaluation of an existing clinical program and our first steps toward expanding that clinical program to other healthcare systems and settings. So this work has not yet been peer-reviewed and published. By way of disclosures, Dr. Schell is the palliative care advisor for DCI, and this work was funded by the PCRC, which we're very grateful for. Today we'll be talking about a little bit of background on hospice in the United States, specific to this dialysis context. A little bit of a description of our clinical hospice dialysis program at UPMC in Pittsburgh, and the corresponding program evaluation. We'll talk some about the development of an implementation bundle and our steps down that path, and then next steps for research in the clinical program. So to start out, what's hospice in this context? So we know that hospice is holistic care for people near the end of life and their families as a bundle. Includes physical and psychological symptom management, spiritual care, education, anticipatory grief, and bereavement care. It's often home-based, as is the case in this program that we'll be talking about today, but it can also be on an inpatient hospice unit. In the United States, hospice is based in a historical context of cancer care, developed largely in the 1980s. It's based on cancer prognostic models. That's where the 6-month time horizon comes from that we know about and we'll talk more about later in terms of hospice eligibility. There's a focus on intensive disease-directed therapy, such as chemotherapy, being discontinued as an eligibility requirement for hospice. and it's generally considered home-based care in the United States. From a Medicare policy context, we do have this 6-month required prognosis to be eligible for the Medicare hospice benefit, which is how almost all adults in the United States get hospice services. Requires discontinuation of life-prolonging or disease-directed therapies, including dialysis. And it's funded, it reimburses hospices per diem at a relatively low rate that's intended to cover symptom management drugs, for example, and those nursing services as part of hospice bundle.
Great, so we'll start with bringing it into the clinical context. So I'm going to talk about a story, Earl's story. So Earl is a 67-year-old retired minister on hemodialysis for hypertension and diabetes for the past year. He has some cognitive and functional impairments related to a past case of meningitis. I followed this patient actually throughout the course of his year on dialysis, and we did a lot of work on symptom management and really defining what quality was for him. And for quality for him was being able to maintain his mental state, be able to be home with his wife. And he was really clear about his goals. His code status was DNR, DNI. It was very straightforward. And yet, about 4 months prior, he was hospitalized 3 times, falls, altered mental status, complications related to the dialysis. And each time we kind of go back and we would say, Earl, do you think we're at a place where we need to change our goals? We talked about hospice, we talked about stopping dialysis, and he just couldn't do it. So he said, I'm just not ready to stop. And so next slide, please. So folks on the chat, I want you to put one word about, as you think about Earl and as this progresses, what do you think the end of life will mostly look like for him? One word, 2 words, prolonged. Thank you, Kathleen. Prolonged. What is that prolonged life going to look like? Okay. Schell says quality. Okay. I'm going to argue to say that it's probably not going to be quality. It's probably mostly going to be spent in the hospital. And what we know in these patients is that end of life is often in the hospital for these patients, in a medical as opposed to a home setting. Great, great. So probably in the hospital. Wonderful. Natalie, just the next one, please. And so as we think about the definition of hospice that Natalie read to us earlier, what is one way that you think hospice could improve Earl's end of life? Back to the chat. What could hospice add to this patient and family's life that he's less likely to get? Comfort. Yeah. Symptom management. Thank you. Wonderful. So really providing patients with dialysis with some of those benefits that we all want and know with hospice would be a start. Thank you.
So keeping Earl's case in mind, I want to talk about hospice utilization in the United States. About half of Medicare beneficiaries receive hospice services. There's evidence that hospice supports goal concordant care, provides a high quality end of life experience and high patient and family satisfaction, and decreases utilization. Best practices are considered greater than or equal to a week in hospice. There's sort of a quality of care analog in cancer where chemotherapy should not be given in the last 14 days of life. We see mean enrollment in hospice is 78 days, and that has quite a tail on it. And I'm going to get into what that distribution actually looks like. So here's enrollment in hospice. This is Medicare beneficiaries by primary diagnosis. You can see that most people enrolling in hospice have a cancer diagnosis, followed by heart disease, and then dementia. You can see chronic kidney disease is clear at the bottom with less than 3% of people who have a primary diagnosis of CKD. Further, we see in the graph on the right-hand side, this is the number of days on average, and you can see the median marked out in the middle, that people from these different diagnostic groups are enrolled in hospice. So the longest time horizon for hospice is predictably Alzheimer's and related dementia. Parkinson's is included in there. This is a disease group that's hard to prognosticate for, generally has slower decline, and people are enrolled for a much longer period of time. You can see cancer toward the bottom, and then followed, of course, by kidney disease, where most people there's a median 8 days enrolled in hospice among those who do enroll. So what's the typical end-of-life experience look like on dialysis? Dialysis is really not designed for end-of-life preparation, and you can see that in the numbers of people with CKD who are enrolling in hospice and their very short lengths of stay. Nephrology clinicians are not trained to have goals of care conversations. They're not necessarily trained to provide robust conservative management of kidney disease without dialysis. And there aren't corresponding financial incentives for those things either. People with end-stage kidney disease and their families have fewer end-of-life discussions than those from other disease or diagnostic groups. And hospice is often too little, too late. So only about 25% of people with ESRD get any hospice. This is compared to half of people, general Medicare beneficiaries who are receiving hospice services. And half of those people with ESKD who are receiving hospice are receiving it for 3 or fewer days. The current hospice payment model is a barrier to hospice utilization for people on dialysis, based on that criterion to withdraw life-prolonging therapies. So what is the hospice payment model? It does require revocation of all life-sustaining therapy related to the primary hospice diagnosis. So the people we're talking about today have a primary diagnosis of end-stage kidney disease, that third admitting diagnosis. The Medicare hospice benefit reimburses hospices per diem. The current model is between $200 and $300 per day, so not very much to cover all hospice services. Hospices are responsible for all costs associated with the primary hospice diagnosis. So if it's related to the kidney disease, in this case, the hospice is responsible for paying for those treatments and services. Hospices are generally unable to afford coverage of dialysis and often require patients to fully withdraw from dialysis before enrolling, consistent with the eligibility criteria. Thus, patients are forced to choose a path that will likely shorten survival notably in order to access any hospice benefits. So Jane's going to talk a little bit about what palliative dialysis can look like.
Yeah, so we saw this as an opportunity to think differently about dialysis. And so at this point, dialysis becomes the barrier for our patients accessing hospice at all, or in a timely fashion. And so what we started to do was flip it on its head and think about, well, how could dialysis be part of end-of-life care? And this is a concept that's actually started well before the vision of concurrent hospice and dialysis. And this was a sense that that dialysis is not a black and white. It's not all about just cleaning the blood, fixing the numbers. That could dialysis actually be also palliative, where the goal is not only to address some of the medical aspects, but also to address aspects that related to symptom control, related to outcomes that matter to patients. And so as we envisioned concurrent care, it was thinking about how could dialysis be part of end-of-life care for patients with dialysis. And now Natalie's going to talk some more about that.
Thanks, Jane. So I want to talk about what concurrent care is and can be. With this definition of palliative dialysis in mind, and thinking about a variety of disease-directed therapies as palliative, so expanding the way that we think about those sorts of things, like Jane said. So concurrent care is defined as the continuation of disease-directed therapy upon enrollment in hospice to support patient goals as they approach the end of life. There are a few guiding tenets of concurrent care. The first is that treatment is motivated by pain control and symptom management rather than curative measures. So the goals have changed. The potential benefits and burdens of the treatments must be balanced with the patient's goals of care and maintenance of their quality of life. And these continue to change over time. Engagement with concurrent care with the treatment during hospice is an ongoing conversation to meet patient and family needs. And treatments must be reviewed on a regular basis to that end. So treatments can be modified and eventually discontinued. So here's some examples of concurrent care. Some of these are models that are more well established than others. So there's TPN, dialysis. We see blood transfusions for certain disease groups. Some interventional radiology interventions. And I just want to clarify here that we'll see some different nomenclature in the space. Jane and I think both tend to say concurrent care, but transitional concurrent care and expanded access are also terms you'll hear for the same thing. And Jane's going to talk about our clinical program.
Yeah, thanks. So the Concurrent Hospice Dialysis Program was really a collaboration between both hospice organization, which was UPMC Family Hospice, and a large nonprofit dialysis company called Dialysis Clinics Incorporated. And what it really took was two large organizations that came together and said, you know what? Patient outcomes matter. How we take care of our patients at end of life especially matters. And that was the only way that this happened. And so through our collaboration, the cost of dialysis was essentially a contracted rate that between the hospice agency and the dialysis company was agreed upon. And upon that rate, the hospice folks actually paid for the dialysis. We're going to talk more about how this dialysis was different than routine dialysis and talk about the concept of palliative dialysis. And with this program, okay, so I'll give you a sense of the program actually allowed for patients to get to hospice earlier and also hopefully longer was our goal. Thanks, Natalie, you can move on. So here's the structure of our program. It was not just let's just give these patients hospice and dialysis. It was that it actually needed a structure. It needed a process by which the clinical teams could identify who would be a patient who would benefit from the concurrent program. And so we made a rough clinical guideline for that. And it was around a prognosis of less than 2 months. The reason we picked this prognosis, which you know is different than the standard 6 months or less that we attribute to hospice, was just to make this financially feasible. The cost of dialysis is somewhere between $200 and $300. And so for a hospice agency to say, yes, we'll pick up some of these dialysis treatments, we really needed to shoot a little closer to end of life than what we would normally do. And this was based on clinical judgment, whether it was hospitalizations, whether it was new or worsening medical conditions, or whether it was a change in functional status, maybe a patient now living in a nursing home, or it was prompted by patients and caregivers. And I'll tell you, when we started the program, most of these patients were identified by our palliative care team and the hospital. And as we implemented the program, including education for the clinical staff, now these patients are actually recognized in the outpatient dialysis clinic. What comes next after identifying the patients is a goals of care conversation. And I want to name that for patients who their goals are hospice and actually wanted to stop dialysis, they were not in the concurrent program. These are only patients whose goals are focused on comfort and they wanted to continue dialysis for their own reasons and their own goals. So once they had that goals of care conversation, the program was initiated. I will name that sometimes that goals of care conversation was happening in the dialysis unit by the staff. And oftentimes it was them alerting either the palliative care team or the hospice team to have a deeper conversation, which really helped the patient and family with that decision. Once the program is initiated, the patient is allowed up to 10 dialysis sessions alongside hospice services. And we gave the 10 again to be feasible economically. And we also have used 10 as a movable number based on the goals of the patient. Next slide, please. So let's talk about this idea of palliative dialysis. And so when we talk about palliative dialysis, we go from trying to make the numbers look good to trying to make the patient feel good. So oftentimes when patients reach this state, they're not eating and drinking a lot. Actually, their needs are quite low from what we would call a dialysis standpoint. So we have an order set that we actually help the nephrologist and the team begin to think of how do I tailor my dialysis care to focus on the patient, their needs, and their goals. And so oftentimes we encourage them to decrease the number of treatments. Consider doing it twice a week. We also think about the time. Most patients are trying to achieve the best numbers they can, and they might be there up to 4 hours. And for a patient who's in a dying stage, they don't need that much time. And so we'll actually help them consider decreasing that time. We also think about fluid removal, less about trying to reach the most optimal hemodynamic standpoint and more around how can we help them be comfortable and not push their body too hard because their body's pretty frail. Everything is adjusted based on symptoms and goals. The medications we deprescribe any medications that are not addressing comfort. These are often the expensive medicines that come with dialysis, vitamin D analogs. They're Ernecoff, erythropoietin stimulating agents. These are not medicines that help comfort, especially for patients at this stage. So we do not check labs. We do not give these medications. We liberalize diet, so the dietitians are also part of the care plan where they can help patients think about how do we liberalize in a way that brings them some joy. Hospice takes care of the transportation to and from the treatment. So they take over that for many of our patients. We keep our patients in their home unit as much as possible unless they go to an inpatient hospice unit. Then they use a dialysis center that is there. The plan of care is revisited at least weekly, oftentimes more often, between the hospice and the dialysis team where they check in and are able to really talk about how are things going with the patient. And at any time, just as with standard hospice, patients can revoke whenever they feel that that is right for them. So here's some of the resources that we've developed as in creating the structure around this program. One is a dialysis order sheet. So this is actually helps the nephrologist and team walk right through how do I create palliative dialysis. I'll also say that since we started the program, we first started in 2018. We've since had 43, now 44, I just have one on right now, patients on the program. We've now included home dialysis, and that's been peritoneal dialysis. So we've created order sets for both PD and HD, as we call it. This helps the teams work together. So when the dialysis team completes the order sheet, they fax it over to the team. Okay. Jen asked a great question about the variation in schedule. Does it create a problem with the dialysis providers? No, I mean, if they're a Monday, Wednesday, Friday, they become Monday, Friday. And they tend to go with it. And we liberalize fluids, definitely, in addition to diet. I will say they're not eating and drinking too much. Then we also have a communication tool because we've just been trying to get better every time we do this. And we did become better by having feedback. So when a patient has had their last dialysis session, the dialysis team actually completes a feedback form to the hospice team, reflections of the care processes. And it really, I have to tell you, many of the changes we've made have all been around the feedback we've received from these teams. I want to name this payment model. Currently, we don't have one. Right now, we are doing this negotiated rate between UPMC, Family Hospice, and DCI. And oftentimes, you really have to be a large hospice organization to say, hey, I can take this on. When we look at reality, many of the dialysis treatments are similar to other expensive hospice treatments. And so in many sense, we are doing some of the standard things that may be happening with use of expensive drugs. I will say the reason that Family Hospice can make it work is that there is grant funding that helps us do this sort of work. Outside UPMC, there are systems doing similar programs. And of course, the VBID model is testing Concurrent now. I will say that this is a hot topic at CMS right now. I've been on 2 calls with CMS, and we're actively doing presentations around this very topic. So there is getting some movement. I'm going to pass it back to Natalie.
Thanks, Jane. I'll also note that there's particular interest from CMS around in the dialysis space, but also concurrent care more generally. So this is a place we expect to see quite a bit of movement over the next 5 to 10 years. So I'm going to talk about the evaluation of the program. Jane mentioned that we've learned a lot. The program has been evolving and changing as we go. And I'll also mention the caveat that this was really a proof of concept design. It's a relatively small program. We've added a lot of structure in order to generalize it. But the intensive effectiveness testing is yet to come. So we started out, there are several components of this evaluation. The first is an early stage qualitative evaluation that we did in 2019. 19 patients had been enrolled in the program at that time. And we conducted semi-structured interviews with a pretty narrow set of people. Bereaved family caregivers of people who had been involved in the program, and then 2 groups of clinicians, those who delivered care as part of the program, those dialysis and hospice clinicians, and then clinicians who referred into the program. So this ranged from specialty palliative care, ICU clinicians, other inpatient clinicians, and a little bit of people from the outpatient side. So in bereaved family caregiver interviews, we got a lot of positive feedback. I'm going to share a little bit of it with you. One family member said this was a way for us to let his body decide. It gave us time. It gave us time to be a family in a quality way. And it was a nurturing environment where we could reach that decision together. So one of the through themes was we have time, and you know, as someone who, as researchers, we can say, you know, we know that a lot of times these patients are dying in the ICU in a very intensive way. And these patients and families were not experiencing that. They were really dying at home in a way that they felt like they had some time to process these things. In clinician interviews, we heard from a dialysis social worker who said, I think the outcome with these families, they feel like my loved one was able to still have control over their decision. The hospice and the concurrent program allowed his body to make the decision for himself. So that's that idea of autonomy and ability to make decisions, again, coming up with the clinicians. We had a palliative care physician say, just knowing that it's an option sometimes alleviates a lot of the fear that can come with these really tough decisions. The idea that as you're helping someone or referring someone into the program, it's not either hospice or this dialysis treatment that you've come to depend on over months and sometimes years. that you really can have both and figure out what the right fit is to meet your goals and manage your care. We also learned of a lot of areas for improvement. In addition to the communication guide and continuing improvement that Jane mentioned earlier, we also learned these themes from the qualitative interviews. The first and foremost were calls for clear workflows, clear documentation, and standardization of the referral process, both from inpatient and outpatient settings. And so we built a lot of communication forms and processes and did education to make sure that those processes were clear and consistent. We also provided structured guidelines for patient identification, including based on the 2-month prognosis guideline and indicators of decline. An additional area for improvement was transportation logistics. This proved to be one of the most logistically complex bits, was figuring out how to get patients to and from dialysis when they were receiving treatments, and who is responsible for paying for that. And it ended up being nested with the treatment payment under the hospice's purview. So the hospice did both the scheduling and payment for transportation fell into their per diem rate. And then patient and caregiver communication and engagement. And that was both in terms of guides for clinicians to introduce the program and also program material. So developing a little booklet that patients and families could take and use. So after that early stage evaluation where we did a lot of clinical program improvement, we did a programmatic evaluation. So this was a bit more structured. We did quantitative and qualitative description. Again, this is still just proof of concept scientifically, but we started to think about what might an implementation plan look like if we want to test this in other institutions. And this is all in preparation for a larger scale pragmatic trial. So quantitatively, I'm just going to show you some descriptive statistics here, our demographic characteristics. A couple things I want to point out, you can see days on dialysis at hospice admission. So this is a mean. You can see some people are on dialysis for years, and then you can see the range in parentheses, some for several years. And then one thing I really want to point out is this last row in the table. About half of people received at least one dialysis treatment after hospice enrollment. So that means that about half of people did not receive dialysis after hospice enrollment. They started hospice and they subsequently decided that, you know, maybe I don't want to continue dialysis. And I'm going to get into the reasons why that may be the case a little bit more in the qualitative description. So here's what we found for dialysis utilization. This is all after hospice enrollment in the concurrent program. So we had people from both modalities. These data are a couple of months old, so we're just starting to bring people with PD onto the program. Most people had been receiving hemodialysis in center. And then you can see that people were receiving about 3 dialysis treatments while they were on the program. So nowhere near that limit of 10. Peritoneal dialysis is defined a bit differently. This is defined as days. So you saw people were enrolled for up to 2 months. Here we have some information about hospice length of stay in the program. So the mean across all patients who were enrolled was 12 days. This is notably higher than the national average in this space. Is just a rough comparison. That's about 6 days. Among people who received any dialysis, the length of stay tended to be a bit longer, almost 18 days, and shorter among those who did not receive any dialysis after enrollment. And some of these people were in acute decline at the time of hospice enrollment. So qualitatively, we learned, we identified several things. And the first thing that we heard repeatedly was that dialysis really complicates the end of life experience for patients and clinicians. So patients do decline clinically on dialysis. Here's a hospice physician who said, we really have the opportunity then to say this patient just went through dialysis and now they're agitated and uncomfortable and moaning. And so thinking about some of those dialysis trade-offs when thinking about enrolling in the program or titrating dialysis after enrollment in the program. Hospitalizations and emergency department use intensify. This is from a family caregiver. And also there's empirical data to this effect that a lot of people are dying in intensive settings and having repeat utilization. There are complexities in late referral to hospice. Hospice benefits are not fully realized. And dialysis can impede transitions near the end of life because, as this hospice manager said, the weight of stopping dialysis is so heavy. It's a really hard bit of momentum to change. We heard that the Concurrent program provides a psychological bridge to hospice. So palliative dialysis, as Jane said, may have some effects on symptoms and is titrated for their goals of care. But a large portion of that is probably psychological benefit based on what we're hearing. It allows people to try hospice, to try to feel safe in a flexible way without foregoing the treatment that they've come to depend on in dialysis. So there is flexibility and the program is goal-directed care. So here's a family caregiver in this middle row. All he had to do was stay as long as his body and his brain could handle it. And those aspects of that were extremely important to both of us. So again, that incorporates a bit of flexibility as well. And it helps patients to feel empowered. It lets people have control over their decisions. We heard that the Concurrent program facilitates goal concordant care near the end of life. So it lets families experience some quality time together. Death can happen peacefully at home, an end of life goal that's important to a lot of people. And I think probably all of the people who were enrolled in the program that we talked to. It helps patients to accept their deaths, to have time to process. Here's a family caregiver who said she knew what she was doing and that she was going to be in a better place in heaven. So she had some time for some grieving herself. And those who were involved reported positive outcomes. Here's a physician who referred into the program. I think the ones that have gone through this kind of program have done a lot better. And then the last theme that we heard was that, again, just like in the early stage qualitative evaluation that we did, we learned that care coordination and clinician education are integral to delivering high quality concordant care. So these are both areas for improvement and things to remember as we think about implementing and expanding the program. Good communication fosters collaboration, having those communication pathways intact and well used, having a clear referral pathway from multiple referral sources, both inpatient and outpatient. Education facilitates the program, both for clinicians and for patients and families. Lack of coordinated care leads to really rough transitions, and likewise, coordinated care leads to smooth transition. So when things went poorly, they tended to go pretty poorly. And having that coordination is really, really important for a program like this to succeed. So these are the 4 themes that I just reviewed, and we are in Pittsburgh, the city of bridges. So we had to use that as a metaphor for using the Concurrent program as a psychological bridge to hospice, with the goal of facilitating goal concordant care near the end of life. So as part of our preparation for implementation, we convened a community advisory panel. This was a subset of people who participated in the interviews that I just described. It was a 19-member panel, so pretty large, regionally diverse across the United States. And we had multiple categories across our membership, including patients, caregivers, bereaved family caregivers, various clinicians, health system administrators, and some policy folks. And the group got together 4 times over the course of the year with the goal of developing this model of concurrent care delivery. And so this is just sort of a taste of what we learned, that, you know, these are the types of stages that people are moving through as they think about, might concurrent care be a good fit as one is approaching the end of life? And then how does concurrent care map into that process? So you can see the declining health states when ideal engagement with concurrent care might be reasonable, and the corresponding life expectancy. So this is really something that's having an impact at long weeks through the end of life. As using that figure as a guiding principle, we identified critical components for an effective concurrent care program. Again, care coordination and education for clinicians and patients and families. Earlier information and preparation is desired by patients and families. So I think this was one of the things that was surprising to some of the clinicians who were in the community advisory group. That, you know, prognosis is less scary than uncertainty. And of course, there are exceptions to that, and it's important to ask patients and families what they want to know, but a lot of them want to know, and it really impacts decision-making in a positive way. Clear workflows and resources lead to smooth transitions, and it's important to have those in place a priori to avoid rough transitions. And some of that is learning and will have to be health system specific. And then provide clear, flexible guidelines adapted to inpatient and outpatient settings.
Thanks, Natalie. That was a great summary. I want to help you understand what happened to Earl on the program. So, you know, after about the time that we started the program, Earl was still my patient. And so I was able to offer he and his wife the program. And, you know, it was a non-decision. The fact that they didn't have to stop dialysis changed everything. So he went home. He received 5 more treatments. He did them twice a week instead of 3 times a week. And the best part was that he was home during all of that time. He had a daughter who was out of the state, and she came home. They had family dinners. They read from the Bible. Their faith was so important to them. And she, in reflecting on the experience, felt that the program really allowed him to finally have control in a way that he had not had before. And for her, you know, despite all the conversations we had had, despite how clear he was about his goals, it was really critical for them that his body made the decision rather than she or Earl having to do so.
Thanks, Jane. So next steps for this program and research trajectory are to explore opportunities for an implementation bundle, opportunities both in terms of hosting and disseminating and also testing pragmatically. We have order sets, communication tools, and workflow guides for one setting that are excellent templates, but will need to be adapted and adaptable. We're working in partnership with some national palliative care and hospice organizations right now. More to come on that. And then also clinical expansion of this particular program. So Jane mentioned that we're expanding into the peritoneal dialysis space, and also thinking about expanded access concurrent care for other disease groups and treatments. This work is ongoing at UPMC Family Hospice, and those programs are becoming more robust across the board. Again, that dovetails with policy action in the United States that is testing innovation in the hospice space, and how can we think about the payment and programmatic model differently. and of course, large-scale pragmatic testing. So we want to acknowledge our excellent research team led by Erica Motter. We also want to thank UPMC Family Hospice and the representatives there who really were essential to getting this program off the ground. DCI, and we of course want to acknowledge the PCRC as our funder and our mentor on this Project Dialupu. And with that, we would love to take any questions. We'll leave you with Pittsburgh's own Andy Warhol and his version of a memento mori. Thank you.
Thank you, Jane and Natalie. This is so interesting and such an important and under-addressed area of end-of-life care. So really appreciate all that you've done and the practical aspects of this work. So this is now our opportunity to hear questions from those in the audience. I know you've been getting questions sort of throughout the presentation. Maybe while we're waiting for other questions, I had one for you, and that is, so the prognosis of 2 months and that being based on clinical judgment, how is that operationalized? Clinicians, and often clinicians that know patients best are often the ones that have the most difficulty with prognostication. So I was curious about how you operationalized the prognosis ascertainment and if you used any particular tools to do that.
Yeah, that's a great point and a great question. And we're actually thinking about that right now because within DCI, we are scaling to other locations in Nashville and also in New Jersey. And so right now it is very much, what guidance we've given them. So I do some teaching to the staff. We've used the surprise question. So the easiest kind of clinical, a nurse, a social worker, a doctor, APP can say to themselves, would I be surprised if this patient died in 2 months? That's sort of our kind of rough estimate. And then we give them some criteria in terms of what that might look like. And then we actually have them look at some cases and think about it with us. We have deliberately been kind of organic about it right now. I think as we think about looking back and sort of testing to see how sick our patients were that did the program, we would probably use something a little bit more evaluative and some sort of measure, but we wanted it to be clinically useful and not overburdensome. So right now it's really been the surprise question and education.
Really interesting. So it sounds like you are providing some training around prognostication to the clinical staff, which sounds really important. The palliative performance scale, I think, has its highest level of sensitivity and specificity at around 6 weeks or less. So I'm wondering if you've thought about using a tool like that.
Yeah, we do. Actually, that's part of the training as well. And it's actually incorporated into the dialysis IT system at the moment. So we'll probably keep that. We're also revamping our advanced care planning goals of care documentation in the computer. And along with that, we're having some tools. So I think we'll keep the PPS score because that's also a really clinically, and like you said, 6 weeks or less, helpful tool. That's a great point.
Excellent. You have another question. And this is from Jennifer saying, great presentation, clearly an implementation challenge, which you met. What was your model for engaging stakeholders and establishing workflows? And do you see this process working for other partnering hospices and dialysis centers? A very important question from an implementation perspective.
Yeah, so I can address the stakeholder piece first. We were doing engagement within UPMC with people around and adjacent to the program. Pretty much since its inception, this has been a grassroots and a learning model, including that early stage evaluation, which was really on a shoestring budget. That was pre-PCRC. And so we really have been evolving in that way. And that formed the basis of how we were thinking about our community advisory panel. We want people who know this program well, saw it when it had significant areas for improvement and help think about how we could address those areas of improvement. And then in terms of engaging people across the country, we did talk to people who were both interested in building their own programs, starting to build their own programs, starting to talk to their local hospices, some people who were parts of those hospices, and also we included nephrologists who maybe were more skeptical, and both philosophically, and one of the first community advisory panel we had almost got hijacked thinking about these cost questions, which is the biggest question in this space, is how do you pay for it? How do you make this financially feasible? And so it was really good to have those people and the policymakers involved with us to think about those high level things, how can you actually practically get something like this off the ground? And so it was very nice to have people who were clinically on the ground, people who were thinking about the policy, some people who were really trying to make it work locally in non-UPMC settings, and some people who really didn't know where to start. Jane, do you want to talk about workflows?
Yeah, the one thing I just want to add to that is one thing we didn't mention is what is happening in policy in the kidney models. And so there's actually a shared risk, shared savings model that has developed through CMS in the kidney space, and it's called the Kidney Care Choices Model. And essentially, because of the work we've done, they have added a waiver benefit for concurrent care. So now there's actually a mechanism for folks that are Medicare and involved in the CKCC to do this work. And so actually we are part of that group that's talking nationally and to folks about how to do this. In terms of workflows, we all got together. So we got the dialysis folks, we got the nurses from the hospice folks, we got everybody together to really help us think about what's critical. We have a monthly call that we do with all of our sites that are interested in this. And along with our CAP, all of that stuff we bring to them, and we have them all kind of tear it apart and put it back together. And I think that's really helped us with the development. I could never imagine what it's like for a dialysis nurse to be caring for a PD patient, that's on the concurrent program. So I need that expert. And that's what we've really sought as we've developed these workflows.
One of the things we're really struggling with struggling through and trying to be thoughtful about is how to engage smaller hospices. That's the nut that's really hard to crack here. This might be feasible for large hospices, but how can we get this into, small communities, rural communities, hospices with fewer resources and fewer backstops? So that conversation is ongoing. If anyone has thoughts and feelings about that amongst the group.
I think that's true for a lot of sort of smaller organizations who don't have as much margin. So I can imagine that that's true here as well. And I love the fact that you're a part of this conversation with respect to the waiver. That's incredibly hopeful and gives me optimism for better care for this population going forward. So we want to thank both Drs. Ernecoff and Dr. Schell for really enlightening presentation, and something I think we all can take away all sorts of useful pearls from going forward. And also want to remind you to fill out the evaluation, which you'll be receiving later via email. And then in addition to that, next month, we'll be having a webinar provided by Dr. Katie Colburn, who is the head of our Data Informatics and Statistics Core, the quantitative branch, on palliative care administrative data research, which I think will be also very interesting, April 20th. So stay tuned and visit the website to register. And have a great rest of the day, everybody.
Thanks, everybody.